Hello and welcome to part 2 of clinical cases for the cardiovascular belt. Today we're going to be taking a look at some of the commonest arrhythmias that occur within the heart and having a look how these present on ECGs. Following that, we'll also take a look at anemia, polycythemia, leukemia and coronary heart disease before comparing angina, stable and non-stable, and STEMIs and non-STEMIs. So to start with looking at arrhythmias, you can have ventricular or supraventricular arrhythmias. Now ventricular arrhythmias can be as a result of damage to the heart muscle, or they can also be in a normal heart. A ventricular tachycardia is a single, strong firing circuit in one of the ventricles, and usually these individuals do have structural heart problems such as scarring, and this could be from a previous myocardial infarction. In ventricular tachycardia, you'd expect to see between 100 and 250 beats per minute, in comparison to your normal heart rate, which is 60 to 100 beats per minute. The episodes of ventricular tachycardia can be short and under 30 seconds with no or few symptoms. Controversially, they can be long, more than 30 seconds, and therefore require immediate treatment to prevent cardiac arrest and death. On an ECG, you'll see these as wide QRS complexes that can be polymorphic or monomorphic. In other words, are they all looking the same or all looking different? And P waves will usually be absent as well. In terms of ventricular fibrillation, this essentially is multiple weak ectopic sites within the ventricles. It causes unsynchronized chaotic ventricular signals, which causes fibrillation instead of contraction. So your normal ventricles should contract and push blood into either the aorta or the pulmonary trunk to the lungs. In the case of ventricular fibrillation, this isn't happening, and therefore very little or no blood is pumping out to the lungs and the body, and the heart can therefore quickly enter cardiac arrest. On an ECG, it'll look unusual. It'll look like an irregular random wave form. There'll be no P waves, QRS complexes or T waves, and we'll explore this a little bit later on. The treatment for ventricular fibrillation is we need to shock them back into a normal sinus rhythm. Therefore, we must defibrillate them. Now, following looking at ventricular fibrillation, we can also look at atrial fibrillation. So exactly the same thing is going on now within the atria as what was just occurring within the ventricle. So AF, or atrial fibrillation, is a sudden development of rapid discoordinated activity within the atria, and it's actually really common, affecting up to 1.6 million people. Essentially, it's that chaotic, unsynchronized impulse again that's causing the atria to fibrillate and therefore causing an impediment on actually passing blood to the ventricles. It often occurs in patients as a result of another medical condition, so it normally occurs secondary to hypertension, systemic infections or a pulmonary embolism. It's also important to consider the fact it'll change the heart rate. So atrial rate can be very high in atrial fibrillation, but not all impulses are actually passing to the ventricles, and this is due to the refractory properties of the AV node. As a result, your heart rate becomes irregular, and the pulse felt at the wrist therefore will be irregular as well, and may vary in strength. Looking at an ECG for atrial fibrillation, there will be an absence of P waves and narrow QRS complexes. With regards to symptoms in atrial fibrillation, the patient will experience palpitations. In other words, the patient is aware of their own heart beating. Also, they may experience tiredness, shortness of breath, and dizziness. As we've said as well, atrial fibrillation normally is secondary to something else, so hypertension, heart valve diseases, and excessive alcohol consumption can all contribute to the development of atrial fibrillation. Other types of supraventricular arrhythmias include atrial flutter and atrioventricular nodal reentry tachycardia, which is a little bit more confusing. Atrial flutter in itself is an impulse which travels around in a localized self-perpetuating loop within the atria. It's most common in the right atrium as opposed to the left, and it's a reentrant path arrhythmia. It can occur in a normal heart, so it doesn't have to be a diseased heart in any way, shape or form for atrial flutter to develop. But it is most common in hearts where the right atrium has been stretched or enlarged due to pulmonary or vascular disease in the past. Heart rate will be increased in atrial flutter, and this is because the AV node blocks impulses from the atria, which are firing at around 150 to 400 beats per minute. So this is normal. So only some of the impulses are conducted to the ventricles. So for example, for every 3 fired by the atria, 1 is conducted to the ventricles. And the pattern can be regular or irregular, which causes this atrial flutter. On an ECG, we'll see no normal P waves, and instead we'll see several flutter waves, which may give this sawtooth-like presence. We'll see this in a minute when we look at ECGs. Atrioventricular nodal reentry tachycardia is a small reentrant pathway which directly involves the AV node. So it's an impulse which is reaching the AV node, means it's always transmitted to the ventricles, and as a result the atrial rate is the same as the ventricular rate. Now, as we've said, the atria are firing at around 150 to 400 beats per minute, and therefore the heart rate will be regular but actually extremely fast at between 150 and 250 beats per minute. Generally, this is found in an undiseased heart, and it actually can be present from birth. it usually requires a second electrical connection between the atria and ventricles. Now, normally the electrical connection between the atria and the ventricle is only through the AV bundle, which is within the cytoskeleton of the heart. However, in AV nodal re-entry tachycardia, normally there is another connection, and this could be an accessory pathway or a bypass tract, which is formed from incomplete separating of the atria and ventricles during fetal development, and this is why it can be linked back to a condition that can be present from birth. On an ECG, we'll see normal QRS complexes, but they'll be very frequent because the heart rate is so high, and P waves will either be absent or right before the QRS complex, but in most cases they are absent in AVNRT. In terms of taking a look at ECGs, looking at ventricular tachycardia, remember we said that the complexes will be wide, but they can be monomorphic, i.e. they're all the same size, or they can be polymorphic, i.e. they're all different. Ventricular fibrillation, as we've said, it's all over the place. There's no recognizable P, QRS or T complexes. In atrial flutter, we can see that there are no actual P waves before the QRS complex, and instead we've got these flutter waves, these F waves. In atrial fibrillation, we're seeing very, very narrow QRS complexes and no P waves. And in AVNRT, we're actually seeing either a P wave just before the QRS complex or no P wave at all. But most importantly, we're seeing them very frequently. It is tachycardia, so therefore the QRS complexes are very frequent. Torsades de pointes is a condition you should be aware of, so it's a short duration tachycardia that can revert to sinus rhythm spontaneously. It could be congenital or due to medication, and an ECG will show a prolonged QT interval and irregular QRS complexes, which have a sharp turn at the baseline, hence the meaning of torsades de pointes, turning of the points. Wolff-Parkinson-White syndrome is another condition to be aware of. So this is an abnormal band of atrial tissue connecting the atria and the ventricles, and therefore the impulse can bypass the normal conduction pathways. So this is what we're talking about when we said the normal pathways through the AV bundle in the cytoskeleton, but this is an extra conduction pathway that bypasses the normal conduction pathway. And the ECGs here show a really short PR interval. Anemia next, so this is a condition where there is a deficiency of red blood cells or hemoglobin in the blood, and there are several types of anemia that you can have, and these are highlighted here. There are other types, but these are the main ones. So iron deficiency anemia, this is the most common, and it's usually due to a chronic blood loss or an increased iron usage. So things that we could be thinking about here are GI disorders for blood loss and pregnancy for increased usage. Thalassemia, this is an inherited blood disorder causing the body to make fewer healthy red blood cells, and therefore less hemoglobin. Hemolytic anemia, this is when red blood cells are destroyed and removed before their lifespan is up, so normal lifespan is 120 days, but they're removed before this period. Pernicious anemia, this is when the body can't make enough healthy red blood cells due to a lack of vitamin B12, which remember is normally absorbed in the ileum as a result of the secretion of intrinsic factor from the parietal cells of the stomach. In terms of symptoms of anemia, you may see dizziness, breathlessness, chest pain or palpitations. And in terms of diagnosis, we can refer to these really important values here. So men's and women's hemoglobin, all these values can vary depending on the trust and the location of the hospital, but as a given, men's should be between 130 and 180 grams per litre, and women's should be 115 to 160. So notice how women's hemoglobin is slightly lower than that of men's. The mean corpuscular volume, so this is the size of the red blood cell, and this should be between 76 and 90. Hematocrit is the thickness of the blood, and this is affected by how many red blood cells are present. And other values to be aware of are these here, but really these aren't as important in terms of a diagnosis of anemia. In terms of treatment, we can replace the iron. We can give B12 or folate replacement as well if it's a pernicious anemia, and we can give a transfusion in more extreme cases. Polycythemia is essentially the opposite of anemia, so this is a disease state of high hemoglobin or high hematocrit. And remember that hematocrit is the volume percentage of red blood cells within the blood. Polycythemia can be primary or secondary. So primary polycythemia or polycythemia rubra vera is a problem with the blood. So this is an increase in the number of red blood cells due to an abnormality of the bone marrow where they're produced. This can cause headaches and vertigo and hepatosplenomegaly. Secondary polycythemia, however, is a problem associated with an underlying pathology. This is an increase in the production of erythropoietin from the kidneys and results in increased erythrocytes. This resolves when the underlying cause is treated, of course. In terms of general symptoms of polycythemia to be aware of, so people who are plethoric, got headaches, dizziness, blurred vision, tinnitus and paresthesia, that should say, and this is because they'll have an increased risk of thrombosis and hemorrhage. Leukemia is a cancer of the blood, and it can happen in several different ways, and there are many types of leukemia that exist, and some are more common in certain age groups. So remember that blood is normally made up of red blood cells, platelets, and several types of white blood cells, and these are all made within the bone marrow, so that hollow, spongy centre of the bone. In leukemia, one of these cells rapidly multiplies and gets out of control, and this takes over the space within the bone marrow. The new cell that's replicating doesn't have any of those characteristics of a normal blood cell. It doesn't carry oxygen, it doesn't fight infection or aid clotting, as your normal red blood cells, white blood cells, and platelets would do respectively. Instead, it just takes up lots of space within the bone marrow, and therefore it leaves very little space or food for any of the other healthy cells to grow. This can happen in several different ways depending on the type of leukemia, but this is the general underlying pathophysiology. As a result, in terms of what you'll see, we'll see a decrease in red blood cell levels, platelets, and decrease in white blood cell levels due to the fact that these leukemic cells are taking up more space within the bone marrow, and these cells cannot thrive. You may also see weight loss. This may be one of the first signs, so leukemia is using up, remember, lots of the body's energy by rapidly dividing, and they may experience bone pain as the cells start to grow into bone tissue, but this is much later on into the disease. Coronary heart disease, essentially this is caused by atherosclerosis. It's pretty much the same as atherosclerosis because essentially it's a plaque that forms within the artery, and the plaque may rupture and a blood clot may form within its surface. As a result, this may block the coronary artery, leading to a myocardial infarction, but causes behind coronary heart disease include smoking, high levels of certain fats and cholesterols, high blood pressure, and hyperglycemia as well. Angina, essentially, or angina pectoris, this is chest pain or pressure, which is usually due to not enough blood flow to the heart muscle. This can be stable, unstable, or Prince metal, and stable angina is where there is a greater or equal to 70% stenosis, in other words, a blockage by a plaque of that coronary artery. In these patients, they will only really experience symptoms on exertion, and the pain will go away at rest. In terms of unstable angina, this is where there's a 90% or greater blockage of the coronary vessels, and therefore these patients are more likely to be symptomatic even at rest, not just during exercise. With the third type of angina, in other words, Prince metal or vasospastic, this is where the patient may or may not have atherosclerosis. Essentially, it's a vasospasm of the coronary arteries causing the smooth muscle to constrict. It doesn't correlate with exertion, and it can occur at any time. Usually the cause behind Prince metal or vasospastic angina is a platelet thromboxane A2, which causes the vasospasm or vasoconstriction. Be aware of the key differences between angina and MI. So angina, essentially the heart tissue is alive but ischemic, and in an MI the heart tissue has begun to necrose. Lastly, for this video we have myocardial infarctions, and these can be ST elevation MIs or non-ST elevation MIs, and the difference there is what we see on an ECG. But first let's think about an MI in general. It's a heart attack, and it occurs when blood flow decreases or stops to part of the heart or myocardium, which causes damage to the heart muscle, and this is due to a blockage of one of the coronary vessels. If this is for a longer period of time, this can cause necrosis, aka death of the heart muscle. The causes behind a myocardial infarction include plaque rupture and therefore blood clot formation on its surface, and this is as a long-term build-up of atherosclerosis. And this blood clot can completely occlude one of the coronary vessels, which leads to the MI itself. There are several of the coronary vessels that can be implicated in an MI, and the easy way to think about these are the anterior, posterior, and lateral heart on which artery would be involved. But the common theme throughout all of these is that damage occurs to the left ventricle, so most MIs do involve the left ventricle in some way, shape, or form. It's really important to identify a heart attack really quickly, and within 1 minute it's reversible ischemia. It impairs the muscle contraction, but it's reversible. Within 20 to 40 minutes, this is starting to cause irreversible damage to the tissue. In other words, the tissue is necrosing, and there's no way back from this. With regards to diagnosis, the World Health Organization says you must have 2 out of 3 of the following: so a change in the ECG, a clinical history of ischemic type chest pain for more than 20 minutes, and a rise and fall in biomarkers such as troponin. So lastly, let's clinically compare a STEMI versus a non-STEMI. So a non-STEMI will not show ST elevation. In other words, the ST segment may be depressed, as it is in this ECG here, or it may just be normal. So this is a normal ECG in comparison to ST depression. This is because it's only a partial infarct. In other words, it's only affected the subendocardial region, causing necrosis within this zone, the most inner layer of the heart wall. A STEMI, on the other hand, this is a transmural infarct. It's affected the whole of the muscle wall, and the ST segment will be elevated, as it can be clearly seen in comparison to a normal ST segment here. The ST segment is elevated on this ECG. So ECG leads all look at a specific part of the myocardium, and it's really important to be aware of what part of the heart you're looking at in what leads, because this will allow you to assess which coronary artery has been occluded. So that's everything for this video. If you do have any feedback, please do let me know, and I hope you found the video useful. Thank you for listening.